about for a patient with locally advanced disease, not a surgery candidate, but chemoradiation, are you doing broad testing? My sense is a lot of people are. It doesn't necessarily matter squamous or non-squamous when you're in stage 3 and not a surgery candidate. The decision of whether to consider a targeted therapy or specifically durvalumab immunotherapy as consolidation, it isn't an explicit standard of care to do this. But what are your practices? Estela, can I start with you in terms of what the practice is for stage 3 unresectable in terms of broader molecular testing and why?
So we were part of the Pacific trial, and I think that trial didn't require testing, and we were basically consolidating everybody with immunotherapy until more data comes back, and really the long-term follow-up of that trial shows that the patients with EGFR mutation don't really benefit from immunotherapy, like we've seen this message in many other trials. So I want to identify these patients because I would hate for them to have a long-term complication from immunotherapy or progress in the middle of that year of consolidation that is very expensive also and involved. I mean, the treatment used to be every 2 weeks, now it's every 4 weeks, so durvalumab. So I think it's important to identify these patients early because I think you could change the treatment or not even offer immunotherapy. I have a discussion with patients about that. Their immunotherapy is what we think can help after radiation for locally advanced unresectable disease, but it may be that your particular case will not respond to immunotherapy. And then we'll decide together, but it's hard to get, osimertinib consolidation after chemo rad. So what else can you do? Right.
What about the issue? I'm just going to ask for everyone. I suspect that there's relatively little enthusiasm for giving durvalumab for someone with a known EGFR mutation. Is that true? I mean, even though they're in the trial, and this is, I think, an important broad issue for us because I think are carving out more patients in subgroups based on biologically relevant differences, like saying, well, this patient may have been enrolled in a trial like Pacific, but I don't think it would be a good idea. And Estela, one of the other points that in addition to cost, we would be concerned about someone being on durvalumab immunotherapy and progressing and then needing to go into an EGFR inhibitor, especially osimertinib, where Tagrisso, and we can use the marketed names for our patient audience that's familiar to them. There's a real risk of pneumonitis that we would be concerned about. So that's one more disincentive.